Okay, I think we'll get started today. Thanks for joining. We have a great presentation today on chronic kidney disease and diabetes presented by Dr. Alice Chang. I'm very excited about today's topic and the information that will be provided. Just very quickly, would like to thank Janssen today for their support. Um, Today's webinar is supported by Janssen Pharmaceutical Companies. Without further ado, I'll pass it over to Dr. Chang.
Okay, great. So thank you very much, Grace, for the introduction and for arranging all of this. And I welcome all of you and thank all of you for joining in today's webinar. We will be talking about the topic of chronic kidney disease and diabetes. And you'll notice that the name that I've chosen for this presentation is From Famine to Feast. And hopefully this will make sense as I go through the course of this presentation. So before I go any further, these are my disclosures. Having worked in some capacity or other with every diabetes company, primarily in the form of education or in the form of consulting. And in terms of the objectives, so by the end of this, I'm hoping that you'll be able to discuss the importance of considering chronic kidney disease in people living with diabetes, be able to name the 3 considerations when selecting anti-hyperglycemic therapies, and utilize the latest evidence for SGLT2 inhibitors for the treatment and prevention of chronic kidney disease. And you'll see why I'm specifically naming SGLT2 inhibition in the context of this topic. So to begin, I'm going to tell you stuff that you already know. It's always a good way to start a presentation, isn't it? So we're going to start from a place that we're all familiar with, which is, of course, chronic kidney disease is a significant consideration in those living with diabetes. Now, here are the data for those living with type 2 diabetes, but really, this is living with diabetes, be it type 1 or type 2 diabetes. And when we look at the statistics here, 40% of people living with type 2 are going to develop chronic kidney disease in their lifetime. And in an EMR database of US patients, the prevalence of CKD was even higher than cardiovascular disease. And when you look at dialysis cases in Canada, more than 50% of them are attributable to diabetes itself. And we all know that screening for chronic kidney disease needs to be a basic part of what we do to help screen for complications in all of our patients living with diabetes. And that involves the checking for creatinine with an estimated glomerular filtration rate, or EGFR, which often comes now with the lab tests, as well as annual screening with a urine albumin-creatinine ratio. But what we also know, looking at fairly recent data from Alberta specifically, but this is not isolated to Alberta, is that the amount of screening that's happening at the primary care level is not as high as you would expect it to be. Whereas this recommendation to do annual screening has been around for years and years and years and years. It is not a new recommendation, but the screening is still not happening at as high a level as we would like. So I would think for everybody who's listening to this, who is clearly engaged in diabetes care, one of the things that I would ask you to ask all of your patients, if you're seeing them, is to say, when was the last time you had your urine checked? And if you're the one who's ordering the test, then of course, please ensure that you're getting a urine albumin-creatinine ratio done in patients on an annual basis at least. And for those of you who may not be ordering tests yourself, but certainly interacting with the patient, when you ask them the question about whether they've had their urine checked, some people are still ordering regular urinalyses, which is not helpful in this situation. So you may want to actually ask them if they're aware of the number called the ACR, or albumin-creatinine ratio, so that they will proactively go and ask their team the next time they're reviewing blood test results to ensure that this is actually being done on a minimum annual basis. And the reason why this is necessary is because the very definition of CKD and diabetes is based on the urine albumin-creatinine ratio and or the EGFR. So the EGFR is a function of how well the glomeruli, or the components of the kidney, are filtering. So it's kidney function. The ACR is how much protein is leaking into the urine. And both of these parameters are necessary components for us to determine risk in a given individual. And I'm going to explain this concept in a little bit more detail. But before I do that though, let's think about why do people with diabetes develop chronic kidney disease? Now, we've classically assumed that most people, if not all people with diabetes and CKD, must have classic diabetic nephropathy, which is the classic damage to the kidneys that can occur with persistent hyperglycemia. But it turns out, yes, that is a good chunk of people who have CKD and diabetes, but it's not all of the diagnoses for CKD in diabetes. Someone with diabetes can also get CKD for reasons that people without diabetes get CKD. So for example, hypertension can still be a major cause of CKD in those with diabetes. Ischemic nephropathy, so blockages of arteries so that you're not getting the circulation that you need into the kidneys, or other causes of kidney diseases that can also result in changes in ACR as well as reductions in function. And then of course, classic diabetic nephropathy with the effects of chronic hyperglycemia. So people living with diabetes can have some or all or several of these causes that are in fact contributing to their CKD when they have diabetes. And the reason why we need to have both measurements, we need to have the EGFR as well as the ACR, is because they give us different pieces of information. So what you're looking at here is what's been called the heat map. It's trying to give you a sense of the risk load a particular individual has in terms of their likelihood of progressing to end-stage kidney disease requiring dialysis. Now, red represents very high risk, orange represents high risk, yellow is moderate risk, and green is low risk. Now, you'll notice though that there's two pieces to the puzzle. On the left-hand side, you have the EGFR, which is the function of the kidney right now. On the top though, you have the ACR, the albumin-creatinine ratio, the amount of protein that's leaking into the urine. And the reason why these two pieces of information are important is because they're giving you different looks at what's going on. The EGFR is telling you how close you are to the edge of the cliff being dialysis. The ACR is telling you how quickly your train is moving towards the edge of the cliff. So both pieces of information are important. Even if you're somewhat close to the edge of the cliff, but you've got a low albumin-creatinine ratio, then your train is barely moving, you may not make it to the edge of the cliff. Or alternatively, you may be far away from the edge of the cliff, but you're in a very fast moving train because of significant albuminuria. Well, you are going to reach the edge of the cliff. So both pieces of information are important, where you're at and how fast you're going. So when you look at this concept is very clearly outlined in this heat map. You can have someone who's got normal or even elevated EGFR. So their renal function, if someone were to ask, it'd be like more than 90%, right? Sounds like you got fantastic kidneys. But that same person though, who has significant albumin in the urine, that kidney is not normal. That kidney is currently filtering normally, but it is not a normal kidney. It's leaking a lot of protein. That kidney is going to progress to significant problems in the near future. And you can see that person is orange, meaning they're actually at high risk. Or you can have someone who's got not a whole lot of protein leaking, and they could actually have a GFR that we would say, 30 to 44% function. People would hear that and freak out and thinking, oh my gosh, my kidneys are terrible. And I mean, they're not great, but they're certainly not in the red. And the reason is because they're actually not leaking that much protein. So they are closer to the edge of the cliff, but they're not moving very quickly. So that's why both concepts are important when we're trying to diagnose chronic kidney disease. And it's not just progression to dialysis, but there's also a close association with cardiovascular disease in those who have chronic kidney disease. So in the purple box, cardiovascular mortality risk increases significantly with the progression of chronic kidney disease. So here on the graph on the right, you have the adjusted hazard ratio for cardiovascular death. And then all along the x-axis here, you have decreasing renal function, or GFR. Now clearly, as the renal function falls, your risk of cardiovascular mortality goes up. But the different colors you see here, the red, green, the blue, represent different levels of albumin creatinine ratio. So different levels of albumin in the urine. And if you notice the red group, the group who's got double-digit ACRs, even when their EGFR is what we would have called normal or even high, they're already at elevated risk. And then, of course, as their EGFR declines, that risk climbs. And in those people, though, who truly have no albumin in the urine and have great kidney function, their hazard ratio is still sitting at 1. And then as their EGFR declines, that level starts to go up. So both pieces of information important to assess risk, and it's risk of progressing to dialysis as well as risk for cardiovascular endpoints. The other reason why we care about chronic kidney disease and diabetes is related to the treatments that we give to manage the diabetes part, the glucose part of diabetes. And we know that the presence of chronic kidney disease is a significant risk factor for severe hypoglycemia if someone is taking medications that can cause it. In other words, sulfonylureas or insulin therapy. Now, when we think about the pillars of management of chronic kidney disease and diabetes, established now for multiple decades, is that glucose control on the far left, blood pressure control in the purple, and the use of ACE inhibitors or ARBs in the pink are established pillars of management of CKD in diabetes, and also pillars of prevention of CKD in diabetes. And we've known about this for many, many, many years, not news to anybody listening to this. And if we think about the glucose target piece, we've incorporated this into our A1C targets. So we are saying that most people should aim for 7% or less, but some people can aim for 6.5 or less, particularly to reduce the risk of chronic kidney disease and retinopathy, as long as we can do it without increasing hypoglycemia. And then we have a group of patients we're all familiar with in the yellow, where we may choose a higher A1C target, and then of course, end of life care, not a concern. But the concept that achieving A1C targets is important for protecting the kidneys is not a new concept. How we do that, how we achieve the A1C control does require antihyperglycemic therapies. And when selecting those, we do need to be mindful of the renal function. So what are the things we need to be mindful of? The things we need to be mindful of are, is this person with reduced EGFR, what might this antihyperglycemic do to them? So is it that this antihyperglycemic has reduced clearance and therefore they're going to have more hypoglycemia? Is it that the efficacy of this antihyperglycemic in this patient with reduced renal function is now going to be less? Or is it that this medication will accumulate in this patient with reduced renal function? So when we're looking at a patient with a reduced EGFR and we're analyzing their antihyperglycemic list, these are the 3 questions to ask ourselves. Are any of these going to cause hypo? Are any of these going to not work as glucose lowering therapies? And are any of these going to accumulate? So what are examples of each? So in terms of question number 1, is hypoglycemia going to be increased? Well, the best example we have is glyburide. Glyburide is renally cleared. Glyburide's metabolite is biologically active and also renally cleared. So in someone who's got reduced renal function, arguably even less than 60 for their GFR, the glyburide is going to stick around longer than it should. And we have all seen the patients, typically an older patient who developed some sort of gastro and has been on glyburide for the last 40 years and nobody thought about getting rid of it. And then their EGFR drops because of their marked dehydration. And then they're stuck in emerge or the hospital for the next 48 hours on a glucose drip eating Tim Hortons all day long because they got significant hypoglycemia because of that glyburide sticking around for too long. So glyburide is a good example of number 1. In terms of number 2, reduced glycemic efficacy, the best example for that would really be SGLT2 inhibitor. So SGLT2 inhibitors are amazing medications for cardiovascular as well as renal protection, which we'll talk about. But below a GFR of 45, they're really no good for glucose lowering anymore. They're no longer really glucose drugs. They are kidney drugs, heart drugs, but they're really no longer glucose drugs. And then in terms of accumulation, the examples there would be metformin, for example. So below GFR 30, we tend to talk about stopping metformin. because of potential accumulation, which in theory could then lead to lactic acidosis, a rare complication, but a potential one. The other thing we might think about would be DPP-4 inhibitors. Now, in the case of DPP-4 inhibitors, there's no toxicity, but there is accumulation. Therefore, you can use a lower dosage as the EGFR falls because it sticks around longer and you just don't need as big of a dose. So these would be examples of these three questions that we would ask ourselves about. Hence, figures like this have been created, and you've all seen something like this. This gets updated periodically as product monographs are adjusted. This is looking at the spectrum of EGFR from left to right, so sort of dialysis through to completely normal renal function. And then the different lines represent different agents within different classes. The color scheme is that the dark green represents go ahead, use it, don't worry about it. The lighter green represents go ahead and use it, don't worry about it, but you may just need to adjust the dose, but you can safely use it. The yellow represents go ahead and use it, but use it carefully because there's something you need to be mindful of, be it hypoglycemia risk, be it some other risk. And then red means don't use it, use something else. So that's sort of what the color scheme is depicting. And as you can see here, the best EGFR to have is over 60. If you have an EGFR over 60, you can use whatever you want. You don't have to think twice. The next level at which we need to think is if you drop below 60, notice that glyburide, there's now a white line, glyburide is now missing. Because below 60, we really ought to be using something else because of that potential for accumulation and hypoglycemia. And then below 50, there's no more white lines, but what you'll notice is there's some light green, meaning the DPP-4 inhibitors can start to be dose adjusted. Not all of them. Linagliptin, for example, does not require dose adjustment, but sitagliptin, saxagliptin, alogliptin, those would be things that you would dose adjust. But I always say this, if you forget to dose adjust, it's okay. Nothing bad's going to happen. Like I said, there's no toxicity. It's just sort of wasted medication because there's more accumulating than necessary for the clinical effect. And then at 45, the only thing to bear in mind is, remember, the SGLT2 inhibitors are no longer useful glucose drugs at this point. They're still fantastic renal and kidney and heart protecting meds. But here, in terms of dosing, the preference would be to use the lower dose at that level. And then you've got 30. 30 is probably the most important number to remember, because below 30, a whole bunch of things disappear off of this, including metformin, including acarbose. The GLP-1s remain, the DPP-4 inhibitors remain, and interestingly, one of the SGLT2 inhibitors remain, and I'm going to come back to that, and that's Dapagliflozin. Now you'll notice insulin on the very bottom of this. Insulin remains on this thing the whole time, and insulin can be used whether you have organs working or not. But it is yellow because, of course, of the potential for hypoglycemia. And then when we get down to dialysis, you've got fewer and fewer options. Some of the DPP-4s are still reasonable to use, perhaps GLP-1. And then when you actually get to dialysis, Dapagliflozin would no longer be permissible, but we'll talk about that later. And of course, insulin is your best friend. So these are sort of going through the considerations based on GFR for how antihyperglycemics need to be adjusted. But that's sort of the A1C piece of the puzzle, and I'm not going to bother showing you the data. The blood pressure piece is well known now for decades. The third pillar, though, remember, was ACE inhibitors or ARBs. And you can see that with the ACE inhibitors and the ARBs, there was significant reduction in hard renal endpoints, whether it be irbesartan, losartan, or captopril. And there are other studies that I could show you. So the establishment of ACEs and ARBs being gold standard for CKD is old. It's well established. And if you look at the dates of these studies, 2001, so 19 years. We've known about this for 19 years. And I would think that 99% of our patients now that we see are already on an ACE inhibitor or an ARB. But our poor nephrology friends have had nothing else to play with for the last, it'd be about 17 years now that they've had nothing new to play with. So since the ACEs or ARBs, not for a lack of trying, because they certainly looked at other compounds and tried to see if there were other things to protect the kidneys, but nothing worked out until the fourth pillar has shown up, which is of course the SGLT2 inhibitors, which are now an established fourth pillar for the management of CKD in diabetes. And the question is why? So we're going to take a step back and think about how to protect the kidney. And one of the ways to protect the kidney is to maintain the lifespan of each nephron. And within the nephron, you have a glomerulus, which is sort of a sac of blood vessels. And in order to maintain that glomerulus, you want to reduce the intraglomerular pressure. If there's less pressure in that sac of blood vessels, there's less chance that those blood vessels will be damaged. I mean, conceptually, that makes sense. So reducing intraglomerular pressure is your ultimate goal. Now, the glomerulus consists of an in vessel, like a blood vessel that's bringing blood in, and then, of course, an out vessel at the end of it. Now, if you want to reduce the pressure in the middle, what you got to do is you can either squeeze the in pipe so that there's less stuff coming in or under a lower pressure, or you open up the out pipe so that you can release the pressure. It makes sense. Squeeze the in or open the out. So with that concept in mind, let's think about what ACE inhibitors or ARBs do. What ACE inhibitors or ARBs do is they functionally open the out. By opening the out pipe, you're going to end up relieving intraglomerular pressure, which will ultimately be helpful for the kidneys. So now let's think about what SGLT2 inhibitors do to the system. And what SGLT2 inhibitors do is they squeeze the in pipe. So if you squeeze the in pipe, you've got less pressure in the glomerulus, which is ultimately good for the kidney. Now, if you use the two of them together, happy days, right? So you're squeezing the in pipe, you're opening the out pipe. Now you've further reduced the pressure within the glomerulus, allowing the glomerulus to live longer, which is the proposed mechanism through which SGLT2 inhibitors are providing this renal benefit. So good news from a kidney perspective. And do the data in fact support this? And the answer is absolutely yes, it does. So this is a little bit offline here, but looking at the cardiovascular outcome trials of the SGLT2 inhibitors, EMPA-REG outcome, CANVAS, DECLARE, so empagliflozin, canagliflozin, dapagliflozin, there was a consistent reduction in hard renal endpoints in these patients who were actually relatively low kidney risk people. So if we take a look on the left here, the blue dots kind of represent where these studies were, and they're sort of more solidly in this green box. So these were not sick kidney people. These were people who actually were cardiovascular people or primary prevention, but still they benefited from a kidney perspective. However, these were not dedicated kidney studies. These were cardiovascular studies that happened to look at kidneys. So what can we learn now from the dedicated kidney studies as to whether there's benefit for those patients? In other words, for patients with established kidney disease and diabetes, do these medications provide benefit? So I'm going to show you the results of the Creatine Study. So the Creatine Study is looking at canagliflozin in patients with type 2 diabetes who have established chronic kidney disease with significant albumin in their urine. So you can see here that they started enrolling patients as long as their GFR was over 30, and they had an ACR of 33.9 or greater. They were randomized to get canagliflozin 100 versus placebo on top of everything else they were taking. Now, the vast majority of these patients were taking an ACE inhibitor or an ARB because well-established foundational therapy to protect the kidneys and also to stop progression. So this was on top of the established data. And what did they find? So what they found was that the study was stopped early because of overwhelming benefit. And it clearly demonstrated in the dark blue that those who were placed on canagliflozin had less renal outcome happen to them. The renal outcome was progressing to dialysis, doubling of creatinine, or renal death or cardiovascular death. So significant benefit for those who were on an SGLT2 inhibitor in a short period of time. One of the secondary endpoints, the key secondary endpoint, was looking at cardiovascular outcomes. Because remember, like I said, those people who've got reduced renal function, elevated ACRs are also at high cardiovascular risk. And Creatine showed us that canagliflozin also reduced cardiovascular outcomes in this population, even though they weren't looking for that as their primary endpoint, and this was in a short study. So again, good news for the patient living with CKD and diabetes. Was it safe? And the answer was yes, it was overwhelmingly safe. So there was initially concerns about things like acute kidney injury. Is this a good idea to be making kidneys pee out sugar? Maybe that's bad for the kidneys. And I think we now firmly understand it's not just not bad for the kidneys, it's actually good for the kidneys. And when we look at sort of renal safety, no issues for renal safety. And when we look at things of other adverse events of interest, such as things like acute pancreatitis, DKA, and fractures, you'll notice that there really was no signal of concern. The DKA signal was a little bit higher with canagliflozin. Again, not surprising given SGLT2 inhibitors, when used improperly in people who should be on insulin instead, or if people stop their insulin inappropriately, then yes, DKA can occur. But if you don't do those things, it's generally very well tolerated. And very importantly, though, lower limb amputation, as shown on the very bottom, not increased in the Creatine study. So I think putting that concern to rest. But as I said, in Creatine, they started enrolling patients starting at 30 EGFR. But some of those patients, by the time they started on study drug, actually their EGFRs were a little bit below 30, like 26, 27. So was it still safe in those patients? Those patients still got study drug. So was it still safe? And in the sub-analysis, it turned out, yes, it was. Those patients who did start off with an even lower GFR did have protection of their kidneys in terms of less decline in the function, but also safety was well established in this situation in that there was no signal of worse safety. So therefore, the indications for canagliflozin have in fact been adjusted to indicate that. And this table is not showing up properly, but I'll verbalize what it's saying. What it's saying is that if you have an EGFR above 30, you are welcome to initiate canagliflozin. Now, the dosage you're going to use is typically going to be the lower dose of 100 milligrams. And then if their EGFR is over 60, you could use the 300 milligram dose. But I'm going to tell you right now, I pretty much stick to 100 milligrams of Cana, 10 milligrams of EMPA, 10 milligrams of DAPA. I do not very much use the other dosages, and I'll explain why at the end. But over 30, you can go ahead and start. And then for someone in whom you already have on it, but their EGFR falls over time and they actually fall below 30, you're actually now allowed by Health Canada indication to continue the canagliflozin below 30, right down to dialysis, because of the potential renal protection that can come with that in those patients who were Creatine-like, so in those patients with significant albuminuria. So this is the first SGLT2 to have this change in indication. I don't think it will be the last, because the way the Creatine study was conducted was that you were allowed to stay on drug even if your EGFR drifted down. So I think we've definitely moved from, I don't know, these drugs might be bad for the kidneys, to, okay, these drugs are safe for the kidneys, to, oh my goodness, I need to use them in people with bad kidneys. Like, that's the progression that we've made, and that's the progression that we're going to continue to have. Because it's not isolated to Creatine and canagliflozin. We now also have data with Dapagliflozin in the DAPA-CKD study, looking at patients with chronic kidney disease. But what was interesting about the DAPA-CKD study was that it actually included patients with a GFR down to 25 and an ACR of 22.6 and higher, so a slightly lower threshold for ACR. But the most important thing about DAPA-CKD is the fact that you had patients with and without diabetes. So now SGLT2 inhibitors are outgrowing the borders of diabetes and starting to help people without diabetes as well. And patients were randomized to get DAPA-10 or placebo on top of standard of care, so on top of ACE inhibitors, on top of ARBs, etc. And what they found was that, first of all, about 30% of the patients in this study did not have diabetes. So that's pretty impressive, and we'll want to see the data sort of sliced out between those with and without diabetes. So what they saw in their primary composite endpoint was significant reduction, strikingly similar to what was seen in Creatine, which really I think is consistent narrative that SGLT2 inhibition is good from a kidney perspective. And when you look at whether or not someone has diabetes, which is shown here in the red, doesn't matter. So this benefit that was demonstrated in this case with dapagliflozin is consistent with or without diabetes. So you are now going to see the use of these therapies outside of diabetes in people with other forms of chronic kidney disease. And then when they looked at sort of other outcomes, this was the main primary outcome. So yes, of course, that was reduced. And then if you look at different components of it, or you look at CV death or hospitalization for heart failure, or even all-cause mortality, you're seeing benefits for these patients. So I think that the benefits now are quite clear for patients with chronic kidney disease. Now, the other thing that we're looking forward to, though, is the third of the SGLT2 inhibitor in kidney disease studies, which is Epikidney. And what's going to be interesting about Epikidney is that they are also recruiting people with and without diabetes, but their threshold for entry is even lower. So it's an EGFR of 20. And they're also going to include a group of patients who do not have albuminuria. So we started off learning with full confidence that in those who have significant albuminuria, there is benefit. And then we learned that actually that expands even beyond diabetes. And then with Epikidney, we're going to learn whether it's also helpful even in those with less albuminuria or no albuminuria. So if we sort of put that into context, this is sort of where the traditional cardiovascular outcome trials have borne out. And then this whole thing needs to be shifted down a little bit. Credence was looking at this population, DAPA-CKD this one, and then Epikidney, you're going to see an even further expanded one. So all this information has updated guidelines, of course. And KDigo is an international organization that looks at kidneys and provides kidney recommendations. And this is one of their figures, which of course is recommending lifestyle modifications to help all patients. And the first line pharmacotherapy in someone with diabetes and CKD, metformin is still there, plus an SGLT2 inhibitor, equal playing field. And you'll notice for metformin, stop after 30 or below 30. For SGLT2 inhibitors, below 30 don't start, but you can obviously start above 30. And then when you get to dialysis, stop. And then after that, if you still need A1C control, that's when the things on the bottom come into play. With respect to other therapies, and they sort of put this into this pyramid to give us a context, all patients should be achieving the things down here. So lifestyle modifications, glucose control, blood pressure control, lipid control. Most patients should receive SGLT2 inhibitors and RAS blockade, and I would argue almost all would fit into this category. And then for some patients, antiplatelet therapies. And then if we look at our own Diabetes Canada pharmacotherapy chapter update, on that left-hand side of the figure, when we look at the groups of patients where we know exactly what to do, you'll notice CKD is one of those groups of patients. And in a chronic kidney disease patient, it is recommended that an SGLT2 inhibitor should be used in order to reduce the progression of nephropathy, hospitalization for heart failure, as well as major adverse cardiovascular events. So I think the role of SGLT2 inhibitors in these patients, well established and really unquestionable. The beauty of this, though, is that it's no longer isolated to SGLT2 inhibitors. And that's why I titled this talk From Famine to Feast, right? Because our nephrology friends had blood sugar control, blood pressure control, and ACE inhibitors and ARBs to play with. And those toys were sort of established in the 80s, 90s, and 2001. And then they had no new toys to play with. And then now they have not just one set of new toys to play with, SGLT2 inhibitors with proven benefit, but now there are multiple sets of toys that they're going to get to play with. And the reason I say this is these are two other types of medications that are being looked at. So Fidelio DKD is a study of Pheneronone, which is a non-steroidal mineralocorticoid receptor antagonist, not something that you are familiar with because we do not yet have it available in Canada, but likely will in the not too distant future. It's a distant cousin, and I mean very distant cousin, to spironolactone or eplerenone. So those may be names that are a bit more familiar to you. But Pheneronone, the Fidelio study was actually completed, and I'm going to show you those data. And then on the right-hand side, there's an ongoing study looking at semaglutide, a drug all of you are very familiar with, a GLP-1 receptor agonist. And that study is ongoing and is actually going to ask the question, is semaglutide protective of the kidneys? And that's something that we'll find out in the next number of years. So let's take a look at the Pheneronone Study, or Fidelio DKD, which was just published at the end of October. So in this study, like the other ones, they took people, though only with diabetes, so type 2 diabetes with chronic kidney disease, and randomized them to receive Pheneronone or placebo on top of standard of care. So again, on top of ACE inhibitor, on top of ARB, still achieving blood pressure and blood sugar control. And what they ended up finding on the far left is their primary composite endpoint, which was kidney failure, so progression to dialysis, or sustained decrease in GFR or renal death, significantly reduced in the blue line, those on Pheneronone, compared to the red line, those getting placebo. And then on the right-hand side, you've got sustained decrease of GFR. And again, you see sustained reductions in those receiving Pheneronone compared to those who are receiving placebo. And then in terms of secondary cardiovascular outcomes, as shown on the bottom here, their key secondary composite outcome, which was a cardiovascular one, also reduced. So now there's a bit of a feast. Now you've got SGLT2 inhibitors, and you could also add Pheneronone to that list of therapies to help people with chronic kidney disease. So we have established now 4 pillars: glucose control, blood pressure control, ACE inhibitors or ARBs, and now we can add SGLT2 inhibitors. And perhaps in the not too distant future, we'll add a 5th pillar, which would be Pheneronone. And I'm hoping there are more and more pillars that will get added over time, like perhaps semaglutide and GLP-1 receptor agonists will be added as a 6th pillar. But this is all just good news from a patient perspective for those who are living with chronic kidney disease in diabetes. So to summarize, CKD in diabetes is common, and our job is to go looking for it. So we need to make sure that our patients are getting a creatinine with an EGFR done at least annually, and certainly a urine albumin creatinine ratio at least annually. And then if someone does have reduced renal function, and obviously we're going to address the A part, or the A1C, or one of the pillars, we're going to use antihyperglycemic. So we need to then ask ourselves, is there a risk of hypoglycemia? Is there a risk of accumulation? And is there an issue with lack of efficacy? And if there are any of those, then we just need to adjust accordingly. And remember the 4 established pillars of management at this point: glucose control, blood pressure control, RAS blockade, and SGLT2 inhibition, and soon to be additional pillars to be added. So I'm going to end sort of my formal presentation at this point. I'm going to stop sharing. I invite all of you to type questions into the chat, and I'm happy to try to address them as best I can. What I did not talk about in the course of this presentation were patients on dialysis and how to address them. And if that would be of interest to the audience, feel free to throw that into the Q&A. Let me just open the Q&A here and open to any questions that people might have. So maybe what I'll do while I'm waiting for, oh, well, there was a question that came in. Okay, so is there a place for SGLT2s in type 1 diabetes and CKD? It's a great question. The SGLT2 inhibitors have now been studied, or several of them have been studied in type 1 diabetes, not specific to CKD, but just type 1 diabetes in general. And they have consistently demonstrated things we would expect: improved glycemic control, less variability, weight loss, blood pressure. However, they have also demonstrated increased diabetic ketoacidosis. So in North America, they have not been approved for use in type 1 diabetes. However, they are approved for use in Europe in those who have type 1 who have elevated BMI, and also approved in Japan. So to answer the specific question about type 1 diabetes and CKD, currently we do not yet have data looking at SGLT2 inhibitors for that particular population. But the other cool thing about Epikidney, which is the study we're waiting for, is they are including some people with type 1 diabetes. They're not excluding people with type 1. So we will get some data in type 1 diabetes with CKD to see if SGLT2 inhibition is beneficial. I don't think there's going to be a lot of patients, but I think there'll be enough for us to take a look at. I'm very confident that people living with type 1 are going to benefit in the same way, just like they benefit from RAS blockade, because the mechanism through which the benefit is occurring is independent of diabetes. As I showed you in DAPA-CKD, those without diabetes also had benefit. So the benefit has nothing to do with A1C, has nothing to do with sugar itself. It seems to be something else. Therefore, I would expect that those living with type 1 would benefit as well. However, there is an increased risk of diabetic ketoacidosis. So we would need to be very careful if we're going to use this off label and select our patients carefully, educate our patients very well, and ensure that they have the tools to watch for a problem if it shows up. Just to comment, I'd be interested in further information for clients on dialysis. Absolutely. So for the dialysis perspective, it would be dependent on whether we're talking hemodialysis or we're talking about peritoneal dialysis. Let me start with peritoneal dialysis. So peritoneal dialysis, I actually like it as an example of understanding how insulin works and choosing therapies accordingly. So in a patient who is on peritoneal dialysis, there's different forms. There may be people who just do overnight PD on a nightly basis. There are some people who do continuous PD and they sort of change their fluid out every 4 hours. But remember, the PD fluid, the peritoneal dialysis fluid that they put into their peritoneum is glucose. Glucose is the osmotic factor used to sort of, suck out the toxic stuff so that you can then flush it out. So when they have fluid in their belly, they're actually eating, but they're slowly eating over the number of hours that it's sitting in their belly. So for patients who do overnight PD, the best insulin for them is actually NPH, because NPH, given when they first put that fluid in or a half hour before they put the fluid in, and they're usually the fluid is in them for about 8 hours or so, well, that's sort of what NPH is doing. So you're kind of providing more insulin during the time that they're pseudo eating through their peritoneum because of the dialysate fluid. Contrast that with a patient though who's actually got continuous PD going on. Well, then they're just continuously eating and they're sort of getting extra glucose the whole time, in which case a longer acting flatter basal would probably make more sense for that kind of patient. In a hemodialysis situation, then it's very patient dependent. For most patients, their blood sugars tend to drop on the day that they're getting their hemodialysis. So then you'll need to adjust their insulin accordingly, taking into account when they go for their dialysis. So some people are morning shift, afternoon shift, some people are nighttime. So understanding that will then allow you to tweak your insulin. So I think in the past, people used to put insulin into, or they talk about insulin in PD fluid and stuff. That doesn't work. So therefore, we're really thinking about the kind of dialysis they're getting and then the kind of insulin to match what they require. Would you be able to comment on diabetic ketoacidosis with use of SGLT2 for use in glycemic management and kidney protection? How would we manage DKA when using an SGLT2 inhibitor? So the first thing to remember is that diabetic ketoacidosis is a result of missing insulin, excess glucagon. You need both of those things to be in place in order to make ketones in order to get ketoacidosis. SGLT2 inhibitors do not cause DKA to occur. Missing insulin, excess glucagon cause DKA to occur. What SGLT2 inhibitors do is they can mask diabetic ketoacidosis. Because, for example, if I was someone living with type 1 diabetes and I did not take one of my insulin injections, and at the same time, the reason I didn't take it was because I was sick with the flu and wasn't eating well. So then I thought, okay, I'm going to skip my insulin, but because I'm sick, I'm churning out glucagon as part of the normal hormonal response. So now I've got excess glucagon and I'm missing insulin. I'm now going to go into DKA. I'm going to be making ketones and I'm going to start feeling crappy, nausea, vomiting, maybe abdominal pain. But one of my clues that something is wrong is that my blood sugar will be 25 or 30. Why? Because I'm missing insulin and I have excess glucagon. And then that will then trigger me to at least seek help, and then I'll get my DKA diagnosed earlier. But the treatment for it is still give me back my insulin. However, me, same person, same scenario, but I happen to be taking an SGLT2 inhibitor. So I'm making ketones, I'm developing DKA, I'm feeling lousy, but my blood sugar instead of being 25 is 9 or 10. Why? Because that high blood sugar is being peed out because the SGLT2 in place. And then therefore my blood sugar when I check it is only 9, 10, 11, 12. So then I sit at home and I think, okay, well, maybe I just have the flu. So I'm just going to ride it out until I get super sick, go to the hospital. And then at that point, I'll be much sicker in my DKA. And it's possible the hospital may miss it initially if I do go sooner, because they check my blood sugar and it's 12 and they think, okay, no way, she's got DKA. And then I sit in the waiting room until I get much sicker. So what it does is it may mask the presentation. It does not cause it, but it may mask it. The other thing SGLT2 inhibitors may do, which sort of affect the threshold to develop DKA, is when I'm on an SGLT2 inhibitor, I do not need as much insulin because I have another outlet of sugar. So if you're somebody who's taking just enough insulin so that you don't get into trouble and you're not making ketones, then there's less of a buffer. And if I just miss one dose, or if I lower my insulin even further, I may actually lower it to the point where I now don't have enough circulating in my body and I start making ketones. So that's why it can mask DKA. It does not cause DKA. And I guess in theory, it could lower the threshold because it allows for a lower insulin requirement. But remember, it doesn't cause it. So the next question you had was around management of it. So if somebody did develop DKA while on an SGLT2 inhibitor, you're going to manage their DKA like you always do. Fluids and insulin, potassium. The only part that's going to be different is you're going to need to add glucose to their treatment to allow you to continue to give high dose insulin a little bit earlier. Why? Because they have another outlet of their sugar still. So their blood sugar will not be as high. So for you to continue to give them the insulin that they need to stop making ketones, you're going to need to supplement with glucose to avoid hypoglycemia. That is the only difference. But the management of DKA, the proper management of DKA is unchanged. You're still going to follow the anion gap, and you're still going to follow the anion gap to determine your insulin dosing. That's still how you're going to do it. And you're still going to give lots of fluids, and you're going to more importantly give potassium to avoid problems related to that. How do you prevent DKA in people using SGLT2 inhibitor? So these are my thoughts. Generally speaking, do not use in type 1. I just finished telling you I do use it in type 1 in special patients. But generally speaking, do not use in type 1 diabetes, because that's the group that is obviously at highest risk of developing diabetic ketoacidosis. Number 2, in a patient not yet on insulin with type 2 diabetes who should be on insulin, please give them insulin. Do not add the 5th medication, being the SGLT2 inhibitor, because the patient's trying to avoid injectable therapy. It doesn't work that way. If someone needs to be on insulin, and your clues may be they've had diabetes a long time, they're relatively slim, or the last thing you added really didn't do anything, that kind of tells you maybe their pancreas is pooped out. If their pancreas is pooped out, please give them insulin. After you've given them the insulin, you can always add the SGLT2. The third thing is if someone's already on insulin and you're going to introduce an SGLT2, don't stop their insulin. What you're going to do is you may need to dose adjust, but even then I would not preemptively dose adjust. I would warn about the potential for hypoglycemia and teach them to dose adjust, but don't go stopping people's insulin. And then the fourth thing is when you're sick, stop the SGLT2. Because remember what I said at the beginning, to get DKA, you need missing insulin, but you also need excess glucagon. And excess glucagon usually comes from an acute illness. So if I have an acute illness, I should stop the SGLT2 inhibitor anyway so that I do not get dehydrated. But on top of that, that will also help take away the masking effect that the SGLT2 may cause if I go on to develop DKA. So I think if we follow those things, right, not to use routinely in type 1 diabetes, give insulin if insulin is what's needed, do not stop people's insulin when you add an SGLT2, and stop the SGLT2 when you're acutely ill, then that's going to really take care of things, and we're not going to run into the issues around DKA. So long answer, but I think a necessary long answer to ensure the safe use of SGLT2 inhibitors in our population. And while I'm waiting for another question, I will say this, in the handful of patients in my practice who have type 1 and whom I am using SGLT2 inhibition off-label, first of all, I have a very clear conversation with the patient so they know that this is off-label. I explain to them the mechanism of action, but all of those patients have a blood ketone meter and have blood ketone strips. I mean, I would like to tell you all of my patients with type 1 have both of those things, but that's simply not true. However, all of my patients also on an SGLT2 inhibitor do, blood ketone meter as well as blood ketone strip, and very clear instructions that if you don't feel well, Remember that your sugar may be, is no longer a reliable indicator of whether or not you're going into DKA. So if you don't feel good, you're going to want to check for ketones. And I give them clear instructions about that. Okay, great. Any other questions that people have? Okay, well, if there are no further questions, what I'm going to do is just share my screen again. Hang on one sec. Okay. So thank you. Thank you all for attending the session. Hopefully this was educational and helpful to you. As chair of the professional section, I do want to put in a plug for joining the professional membership, and also to leave this slide up for a bit for any of you who are listening who are not already professional members or who need to renew your membership. Please go ahead and do so. But I do see a question coming up. Where do we get the most recent anti-hyperglycemic agent and renal function chart, August 2020? Good question. So I updated it and sort of made that myself. I don't know that Diabetes Canada has officially updated it yet. I am happy to share it with the group. I don't know how best to do that. I guess I could share it with Grace. Grace, I don't know if you actually have emails of everyone who's attending, or I guess we could post it, or Grace, you could post it for me on Timed Right. That may be one way to do it.
Yes, that's exactly what I was thinking. We would post it. We'll create a discussion thread for this presentation, and we will post it in there.
Okay, good. So I'll do that. So I'll send that to you, Grace, and then you can post it on Timed Right. And just bear in mind, it's sort of not an official Diabetes Canada thing, but it's what I've updated based on the product monographs. And also bear in mind that it will continuously need to be updated as product monographs adjust and change over time. But thank you. It's a great comment. And then the final thing, if I've left this long enough to remind people to renew their membership, is of course we're coming up to the holidays, and if you are thinking about doing any donations to charities as part of your Christmas gift giving or any other gift giving, please remember Diabetes Canada in your thoughts for that. And I will end off with a final thank you. Thank you for your attention. Thank you to Diabetes Canada for hosting these webinars. And maybe I'll give the final word to Grace, actually, if you have anything you need to say to the audience.
My last word would be to thank you. This is a great presentation, very informative. Always great to hear you present. So just like to thank you, Alice, for presenting today.
Okay, great. So thank you very much, everyone. And I will send the stuff to Grace, and it'll be on Timed Right this afternoon. So thank you all.
Bye, everyone.